It is a great pleasure to talk to you about my particular hobby, which has been since 1985, ultrasound imaging of the pelvic floor and the lower urinary tract. Okay, that's the disclosures. I'm going to complement what Matthias Oelke just said with an overview of what you can get out of using ultrasound imaging in stress incontinence and prolapse. And I'll say from the start that really in stress incontinence is primarily post-op use and use in people who have got problems after surgery. In prolapse, it's a whole lot more. Now, we have made a lot of progress in the last 170 years since this French gynecologist examined a patient for, well, not sure what he examined her for. Hard to say. But we have had progress, lots of it. And the high marks so far, the high watermarks, been the ICS POP-Q. We assess the anterior compartment, the posterior compartment, we assess the apex and vaginal length, and I've only recently realized that there's a whole lot more there, which is the genital hiatus and the perineal body, which I ignored for about 10 years, and it was really inappropriate because there's so much information there. Why would you want to use anything else? Why would you use anything else except your eyeballs? In particular, if it involves the purchase of expensive machines, or even worse, if it involves begging your obstetric colleagues for access to a machine, which I've been doing forever. The basic methodology is really simple. Matthias has already shown you a minor introduction to translabial or transperineal or perineal imaging. Some people call it introital, and it's been the same for the last 25 years or so. We place a curved array transducer on the perineum in the mid-sagittal plane, and the resulting image includes the symphysis pubis to the left, the urethra, the vagina, the anorectum, the external and internal sphincters are here, the bladder up here, the cervix, the cul-de-sac, and the ampulla of the rectum. When it comes to the assessment of stress incontinence, we're interested in the urethra and the bladder neck. And that's just to give you some idea of the resolution that you get. We do a Valsalva maneuver. This lady is doing a Valsalva maneuver. The bladder neck moves downwards because I'm from the antipodes. Everything's upside down there. So this is down and that's up. And you can also see that the bladder neck, the angle between the proximal urethra and bladder neck changes a little, but the bladder neck stays closed. This lady is continent. A Valsalva that looks like that is completely normal. Now that's not quite so normal, and in fact that image illustrates the typical anatomy of stress incontinence. Or you could even say the typical anatomy of urodynamic stress incontinence. So at rest, there's the symphysis pubis, the urethra from the external meatus to the internal meatus. The dark stripe is the longitudinal smooth muscle and the mucosa. The bright stripes are the urethral rhabdosphincter. That's at rest, that's on Valsalva. So what's happened there is that the bladder necks move downwards by about 3.5 centimeters in that direction. Everything there kind of rotates around the symphysis pubis. The bladder neck opens up. The angle between proximal urethra and trigone opens up to 180 degrees. And I think you might be able to, I think you can pick up that there's some funneling there. This is what happens immediately before leakage. We quantify descent of the bladder neck against the infero-posterior margin of the symphysis pubis, so there's a coordinate system. Here, the X is the position of the bladder neck above the symphysis pubis in the craniocaudal direction. Here is the position of the bladder neck just below the symphysis pubis on Valsalva. To make this more sophisticated, Professor Scheck in 07 or 08 developed what's called a urethral motion profile. You can see that we've labeled the urethra with 6 dots, but you could do it with 100. The system allows any. And all the mobility of these different points along the urethra is determined against the point of reference of the symphysis pubis. And that's led to some rather interesting realization, which takes us back to the 1940s or 50s, because what you see, the association between urethral mobility and stress incontinence is the association primarily between stress incontinence and mid-urethral mobility. Because if somebody's got a lot of mid-urethral mobility, they're much more likely to leak, and they're much more likely to be found to have USI on urodynamic testing. And then there's the urethral rhabdosphincter, and Vic and the group in those that have arisen from King's College, from that unit in London, they've done quite a bit of work on the sphincter in the past with endovaginal probes. The sphincter is not so obvious in the mid-sagittal. You can see the bright stripes here and there, but in the axial plane, it is perfectly obvious. It's a bullseye. And your eye, your visual cortex is hardwired to detect such shapes because it's the eye of the eye of the tiger. That is why your brain is so good at picking up round shapes. And I'm sure your eyes were immediately drawn to that round shape, which is the raptor sphincter. Now, the urethra can also be imaged with endovaginal 3D. There's a lot more detail there, but I'm not sure yet whether we can get any data out of that would be useful to the clinician. Because after all, the clinician has got the MUCP or the MUP or the ALPP, which is a functional assessment of the urethra. More important is that we can do prolapse assessment. So there again is the symphysis pubis, and we put a line through that. The main disadvantage of that is that we have no posterior anchoring point for that line. And I guess we're just lucky that it doesn't matter much, because when you place a transducer on the perineum, there are limited ways in which you can place it because of the anatomy, because of female anatomy. And with a Valsalva, provided you don't angle your transducer, the angle error that is introduced by the fact that we don't have any anchoring point here is minimal. It's certainly applicable for clinical use. It's repeatable enough for clinical use. You can see a cystocele here, the equivalent of a second-degree cystocele here, with an open retrovesical angle and funneling, and you can see the equivalent of a first to second degree uterine prolapse. That specular echo, that line here, that's the leading edge of the cervix. There's the cervical canal, and that's the uterus. And here's the posterior compartment with the rectal ampulla. Now, when we do prolapse assessment by ultrasound, the main issue really is to control for confounders, to get a proper push. And the first issue there is time. This study was done by Francisco Orejuela from Houston a few years ago, and when it says volume down here, that's almost seconds. It's 0.8 or 0.9 of a second, so for practical purposes, see that as seconds down here. And I think it is immediately apparent that it takes 4, 5, 6 seconds to reach 80% of final organ descent. That's very important for clinical examination as well, because lots of people do Valsalvas that are much shorter than 5 or 6 seconds. Everybody who comes to my unit is surprised at how aggressive we are in getting people to push properly. Well, there's a reason for that. And imaging has informed that, because on imaging you continue to see tissues descend. So we don't stop the push after 2 or 3 seconds because the tissues are still descending. So of course we want to keep that lady pushing until those tissues have reached pretty much their final stage. Everybody assumes that Valsalva pressure is an important confounder, and to a degree it is, but it really doesn't matter in practice, which is highly convenient. Femke Mulder from the Netherlands did a study with us a couple of years ago where she showed that in order to reach 80% of maximum organ descent, you don't actually need that much pressure. You need pressures, depending on the parameter, you need pressures in the order between 30 and 75 or 77 centimeters of water. And those of you who do urodynamics, which I guess is a large proportion, would be aware that even the average 80-year-old is going to get to over 80 centimeters of water. What that means is that we do not need to standardize ultrasound prolapse assessment for pressure. We need to standardize it for time, but not for pressure, because everybody is going to get above that threshold. What's more important, actually, than pressure is to control for the confounding effect of a concomitant levator contraction. Because loads of people, when you ask them to push, they're going to squeeze. And loads of them, when you ask them to squeeze, they're going to push. So you need biofeedback. You need visual or tactile biofeedback to make sure they're doing the right thing. And you can see the effect of a levator co-contraction here, because at the start, she's pushing, and at the same time she's squeezing. You can see that because she's reducing the distance between the pubic bone and the anorectal angle here. So she is co-activating the levator, and a lot of people do that. At least 40% of nullips do it, and in some we just can't get them to stop that. In older women, in symptomatic women, if you see a lot of co-activation, you got to stand them up. You got to do the imaging in the standing position, which we don't normally do because it's so much hassle. But in the standing position, just about everybody gets the push right. Well, what can you do? Once you've got the push right, you can distinguish between two very different forms of cystocele. And really, that is something that needs to be explored further. That distinction dates to the 1960s, and it was first described on X-ray, on cystourethropy. In some women with a cystocele, the urethra and the bladder form a line, so the retrovesical angle is open at 180 degrees. Those women are more likely to have symptoms of stress incontinence. They're more likely to have a normal levator. They're more likely to void well. Then there's other cystoceles where the retrovesical angle is intact at 100 degrees or so. The urethra is markedly kinked, and the bladder is a lot lower than the bladder neck. These women are more likely to present with prolapse. They're more likely to have voiding dysfunction. They're more likely to have a levator avulsion. Very different. At the same time, you're going to pick up masses. Most of those vaginal masses are cystic, and the main distinction, the main differential diagnosis there is between a Gardner duct cyst, which is totally harmless, and you can do something about it or not, it doesn't matter, or urethral diverticula, and that matters. And it's definitely worth trying to diagnose a urethral diverticulum. We would see probably about 5 or 6 a year. And in this particular case, which is one that is that Vivian Wong obtained for us, there's the urethra here, and there's irregularities, cystic structures in the space of retius, and there's even more towards the vagina. This is the mid-sagittal plane. The mid-sagittal, like so. This here is the corona, like so. And this here is the axial plane, like so. So this particular acquisition with a 4D machine is enormously useful when you want to assess localized abnormalities, such as a diverticulum or maybe a sling that's gone wrong, because you're going to see that structure in all 3 dimensions at the same time. It's very useful for surgical planning, as you might imagine. And in this particular case, I thought fixing that diverticulum would be really hard because it reaches all the way around. That is, when you do that vaginally, you've got to work your way into the space of retius, and that can be quite difficult. In the posterior compartment, ultrasound will help you distinguish between the at least 5 different conditions that give you the appearance of a clinical rectocele. A clinical rectocele could be anything. And this is why when we examine patients clinically and we say there's a rectocele, I think that's actually a fallacy. We should not talk about rectocele clinically. We should talk about posterior compartment prolapse. And a posterior compartment prolapse can be a true rectocele, which is here. It's a pocket of the a pocketing of the rectal ampulla into the vagina. It's a radiological rectocele. It's associated with symptoms of obstructive defecation. This here is perineal hypermobility. There's no pocket. The rectal ampulla moves down a lot, but there's no pocket. There are no symptoms of obstructive defecation. The rectovaginal septum is intact. Looks the same clinically. Well, that looks the same clinically too most of the time. This lady has an enterocele. The rectal ampulla is down here. There's nothing happening here at all. With a Valsalva, you see loops of small bowel move down there. There's obvious peristalsis. This is a substantial enterocele. And then there's intussusception, which is something that urologists and gynecologists very rarely diagnose. That's the axial plane, that is the mid-sagittal. Here's the anal canal, which is still kind of tubular here. But look what happens here. This is not stool. This is not stool. What happens there is that this lady is pushing small bowel into her anal canal. She's inverting the rectal ampulla, and in that process, the anal canal changes from tubular to something more resembling a cocktail glass, although it's not that cocktail glassish here, because that trumpeting, that opening up of the anal canal is not quite so marked here. In the axial plane here, you can see an abnormal levator, and you can see how lopsided things are. These are all findings that would normally be missed. And then you can identify slings, and this is something that we sometimes miss. Every month, I see at least one patient in whom there's a sling, and she didn't tell us, or she'd forgotten, or maybe her doctor, God forbid, maybe her doctor never told her. I found 2 slings in somebody who thought that she had 1. That happens as well. So the sling, the suburethral sling, is here, and it compresses the urethra between the pubic bone and that sling. The urethra is still trying to leak. It's funneling here. It's still trying to leak, but that functional sling provides for sufficient dynamic compression. Here in the exoplane renal volume, you can see that sling under stretch. You can see how it curves, and this is exactly what happens in vitro. You can see it happen in vivo. These slings do not have much of an effect on the position of the bladder neck. It's the same patient before and after, and the only difference is that there's that white patch there, which is a transobturator tape, and you can see how the urethra gets compressed by it. It runs pretty much straight here, and here the mid-urethral mobility is impacted on, is changed by the tape. That's what those tapes do. They work by dynamic compression. We can get some interesting data from looking at slings in terms of where they are along the urethra, in terms of how curved they are, in terms of the tape gap, the sling tape gap, which we measure on maximum Valsalva, the gap between the symphysis pubis and the sling. And that is something that is clinically enormously useful. So you got a sling, and maybe something went wrong, or maybe it was done by your newest trainee, and you just want to know, or the trainee may want to know whether they've done it like the boss does it. Well, just look at it. Is it straight or curved at rest? The more curved it is, the more under tension it is, even at rest. And the closer it is to the symphysis pubis, the more compressive it is. The effect of that compression will depend on what's in between. It will depend on the quality of the urethra, but you can certainly tell whether you've put that in really tight or really loosely. And a sling pubis gap of 15 millimeters is way too high. That's a sling that's simply been put in too loose. A sling pubis gap of 7 or 6, that's a really tight one. And maybe one should look at technique if that happens a lot. And then there's lots of complications from slings. You know that. You know it. If they're too tight, you might want to cut them. You might want to see whether the colleague at St. Elsewhere has managed to cut the sling, because sometimes after cutting them, the sling's still intact. I'm sure you've noticed that too. You want to know whether he's truly managed to cut it, or whether you yourself have truly managed to cut the sling. And then you want to deal with the really odd cases like this one. Here's the urethral rhabdosphincter. You can see that this sling is clearly perforated. It may take a while for such a sling to actually become visible in the urethra, but eventually it will become visible. And in this case, somebody's tried to divide it. He had to divide it laterally because he couldn't find it in the midline because it's straight through the urethra. This also helps enormously with surgical planning. What you need to do here is go into the fornix and pull it out there. And then you just close the urethra and everything's fine. Identifying meshes. That's another huge field that is clinically of high utility. These meshes are found in the anterior compartment meshes are easier to see. Here, that's the line of the mesh in the mid-sagittal, in the coronal, and in the axial plane. We found on ultrasound that these meshes don't actually shrink very much at all. So ultrasound has provided a lot of information on the, as it were, the natural history of those meshes. Mesh failure is a major indication. So this lady has a completely normal anterior compartment mesh, which is still in place, and it's working well. It is doing its job. It's holding up well. It's still anchored firmly. It's here. Okay? There's a cystocele recurrence. This cystocele is what we call an anterior recurrence. It is anterior to a well-anchored mesh, and that's easy to fix. That's really easy to fix. You just need to dissect the cystocele, identify the top end of the mesh, and anchor the bladder neck and the trigone to that mesh. Very high success rate with that. There's other types of failures. There's a mesh again, and I think you've probably seen that. I might be able to play that again. You may have seen that the top end of that mesh is completely loose. See that? The top end is here. That's the apical end of that mesh, and just watch what happens with it. Whoop. That means this lady needs apical anchoring. She's got a recurrent cystocele, which we call an apical recurrence. She needs the apex of that mesh anchored. And we can see failure even if it's completely inapparent clinically, because this lady's had a posterior compartment mesh here, and in the vagina she has no prolapse. It all looks fine. But now she complains of bad symptoms of obstructive defecation. She now has a rectal intussusception, which is getting close to a rectal prolapse. You can diagnose ballooning, which is the distensibility of the of the levator hiatus. And maybe just watch this down here. It's a really old clip, which I keep for nostalgic purposes, because I didn't understand what was going on when we did this clip. And watch what's happening here now. She's doing a Valsalva. It's enormous. This levator is sufficiently wide to admit the passage of a 34-week baby. It's not surprising at all that she has a prolapse. Anyone would have a prolapse with that. This is a hernial portal. Prolapse is a hernia that occurs through this hernial portal. The larger the hernial portal is, the more likely is prolapse, the more likely is prolapse recurrence. It's not surprising at all. And then, of course, you've seen it several times now during this meeting already. We diagnose avulsion. This is the typical tomographic imaging of an avulsion, so I'm not even sure whether I need to explain this anymore. There's the symphysis pubis here in front with the pubic rami here and there. The symphysis pubis is closing in that slice and is closed there at 2.5 millimeter interslice interval. This is a thin but intact muscle here on the patient's left because we're looking at her bottom. And this is an abnormal, an avulsed levator on the right. This is the patient's right because we're looking at the bottom. That defect is all the way through the volume. And once you can pick up, once you have the imaging to confirm your diagnosis, you may actually pick up an avulsion just by looking at the patient's bottom. Watch what happens here. Can you see how lopsided that prolapse is? Can you see that? Behind this is an intact levator here and a full avulsion there. When she does a pelvic floor contraction, everything gets pulled to this side. When she does a Valsalva, the same thing happens because the prolapse primarily develops on this side. If you look at the skin grooves, even the skin grooves are different. And if you were to measure this distance here, this distance is higher than that distance. We never noticed. We never knew. Now, imaging is going to make your clinical examination skills better. And this is our palpation model. I've got about 30 in the bag or so. If anybody's interested, please, you're welcome to pick one up. This is a realistic model of the female pelvic floor, of an abnormal female pelvic floor. The avulsion defect is here, and this is what it looks like in our palpation model. It's really like that, and it's not difficult to pick up. But I would imagine that a bit of imaging confirmation helps with convincing yourself that you have truly palpated the major abnormality that you can pick up on clinical examination of the pelvic floor. And we do that because it matters. There are several papers, both on MR and on ultrasound, that have shown an association between avulsion and prolapse, and I think there have been several more at this meeting. It doesn't matter so much for the posterior compartment. More important for the surgeon, it matters for prolapse recurrence. And there's now 7 or 8 papers now that show that avulsion is a strong risk factor for prolapse recurrence, in particular in the anterior compartment. Together with the realization that hiatal area matters for prolapse recurrence as well, we've constructed the first version of a prediction model for prolapse recurrence, and this is only for the anterior compartment. It's not very sophisticated yet. This is the probability of a second-degree ICS POP-Q second-degree anterior compartment prolapse after an average of 2.5 years. This is based on 334 data sets. This is in women with avulsion. This is in women with an intact pelvic floor or in women without a full avulsion. That is the effect of mesh. Mesh seems to have a compensatory effect on avulsion in that if you have somebody with an avulsion who got a good anterior compartment mesh, this curve results, which is quite similar to that. That is recurrence in women who do not have a full avulsion, and you can see that the use of mesh in these women seems to make no difference at all. Now, you tell me whether that is clinically relevant or not? Well, surely it is. So, to finish, why do we need imaging at all in those patients that we see for stress incontinence and pelvic organ prolapse? We need imaging to make us better in examining clinically because we are not very good at it. We've recently worked out that you can detect a true radiological rectocele with your finger. PR. You can do that. It needs training. And the only way you can get that training is by having imaging for feedback, to tell you whether you've been right or wrong. When it comes to examining the levator for avulsion, I reckon by now I'm as good with my finger as I am with the ultrasound machine. But it takes a long time. It is a skill that has a substantial learning curve. On imaging, we can teach anybody within a week. Anybody. And the reason for that is that our eyes are our primary sensory organ. It's not our fingertips. it's easier to teach our eyes. It'll show us findings we never suspected. For example, a urethral diverticulum, which routinely gets missed. It can help us with patient selection for mesh surgery, which I hope I've shown you just now. It enables meaningful clinical audit. Because isn't it an absolute disgrace that we've been doing posterior compartment repairs, posterior corporophy defect-specific procedures for, cumulatively for 100 years, and there's virtually no decent outcome data in the world literature. If we want to fix symptoms of obstructed defecation, we need to fix the pocket. If we want to fix a prolapse, well, the first thing is not to fix a questionnaire, for God's sake. The first thing is to fix the anatomical abnormality. And then there's research into etiology and pathophysiology, and I really don't need to make the point because up to this point at this meeting there have been like between 25 and 30 papers that used ultrasound measures as primary outcome measures. So obviously people realize that it's a very useful tool for research. And finally, I think what imaging is now starting to do is by demonstrating pathophysiology, true pathophysiology, and by helping us with the elucidation of etiology, imaging is now starting to help us tackle underlying problems rather than just the symptoms. I should point out, because we're in Spain, I should point out that on my website, which you can find if you just put in my email address or my full name into Google, we do now have a Spanish version of the website, which has been translated by a Chilean fellow of mine. I think the most important issues now are in training, in teaching and training. We do that for our fellows. We do it for visiting scholars, now 2 a year in Sydney for 5 weeks. And we do it via websites. And I hope that, as in the past, in future societies such as the ICS will remain the main forum for teaching and training ultrasound, because it is high time that imaging entered clinical practice generally. Thanks.